All right. Good afternoon, everybody. Andy Whitney here with Tele Health, Brian Telemedicine, here with our friends from CPS with some pharmacy training today to talk about transitions of care, training and education about transitions of care. They'll have some other things to chat about as well, but we're kind of excited to have them here today. They've been a great partner with us. We have them in a number of locations. So I will hand it off to the CPS team to do introductions, and then you guys can take it from there.
Great. Thank you so much, Andy. Hi, everyone. Good afternoon. My name is Alip Modi, and I am the Vice President of Telepharmacy Operations for CPS Telepharmacy. And today we'll be talking to you on transition of care and the impact that pharmacy can play on the quadruple aim of healthcare and patient outcomes as a whole. Before we dive into that deep here shortly, I'll pass it around to our team just so you can have a few introductions as well. We'll start with Karen Alish.
Thanks, Alip. My name is Karen Aller, Senior Vice President over the Telepharmacy Division, and happy to be on the line with you all today. Dave, you want to take it?
Sure. Thanks, Karen. My name is Dave Bono with CPS, Senior Vice President of Business Development. I've been with CPS just over 12 years and based out of Kansas City. So great to be here with you all. Thanks. Todd?
Thanks, Dave. And I'm the Vice President of Business Development. This is Todd Hudnall, focused on our 340B solutions, and been in the 340B space for over 20 years with various companies, and excited to share with you as well.
Great. Thanks, everyone. And thank you all again for giving us the opportunity to speak to you today about CPS and some of our solutions, but more so focusing on transition of care. So just a little background on myself. I've been with the organization now for just under 9 years and help oversee our telepharmacy operations here in Naperville, Illinois, where we service about 180 hospitals around the country with a wide variety of services from remote order verification, medication therapy management, and transition of care. So if you are unfamiliar with CPS Telepharmacy, we're located in Naperville, Illinois, just about 30 minutes outside of downtown Chicago. We have a fully centralized model that allows our staff of 60 plus pharmacists to work out of our office here. Some of the reasons why we like this model is that it allows for 24/7 supervision as well as pharmacist collaboration so that they can turn to their left or right and ask each other any questions. We also have a rotation program that allows rotation students and residents to come through our office and provide routine in-services as well as a grand round style education program. So when we first think of transition of care, one of the largest areas that lead to patient harm is medication non-adherence. You may be familiar with the leaky bucket theory, and which states that for every 100 new prescriptions at discharge, only 50 to 70% are filled at the pharmacy. And of those, only 25 to 30% of patients take their medications properly. And then of those, only 15 to 20% refill their medications. This is, of course, can lead to a myriad of issues that a pharmacist can be primed to help manage. But as you can see here, non-adherence is only one aspect of medication mismanagement, where a larger focus should really be placed on inadequate therapy that takes close to 60% of a lot of the medication issues that occur regarding a patient's care. And when we look at suboptimal medication management, it represents close to 15% of all US healthcare spend at close to $528 billion. For every dollar that's spent on medications, the US spends $1.17 on suboptimal use of those medications. This has also led, unfortunately, to 275,000 deaths per year for medication mismanagement, many of which occur during transition of care. And when we talk about transition of care and what pharmacy can play a role, I think a kind of a step back is really looking at the future of pharmacy. When I first started my career as a pharmacist, I completed my residency at the Veteran Affairs Hospital, and it really opened my eyes to what pharmacists can do and see what you see at a lot of larger health systems as well. The idea that pharmacists are really tied to the idea of enhancing clinical care. You're seeing enhanced data analytics as well as pharmacogenomics utilized, and pharmacists are more and more dependent upon by the healthcare team and work closely with nurses and doctors and by developing collaborative practice agreements. In addition, provider status laws are ever changing, and more states are allowing, and likely more legislation will continue to be passed in the next few years to allow pharmacists full provider status. In addition, payers and regulatory bodies are shifting towards value-based care, which calls out an improvement in patient outcomes. And finally, COVID really opened up telehealth and telemedicine and what role that plays within healthcare and patient outcomes. So when we think of transition care, it's important to discuss what impact it can have on the quadruple aim of healthcare and what that represents. And the quadruple aim, it starts with improving the patient experience. This includes motivating and engaging patients to play an active role in their care to improve patient outcomes and safety. This is ultimately achieved by valuing people, delivering higher values and higher value and quality, improving access, and meeting the patients and the family needs. This is then followed by reducing costs. And by reducing that, you reduce resource utilization as well as readmissions, decreasing ER visits and unnecessary or preventable hospital admissions as well. The third aim improves the health of the population, preventing and managing prevalent, costly, and chronic diseases. This is accomplished by improving health outcomes, the equity of access, and reducing the disease burden as well. And finally, the final aim is to improve provider and work-life balance by creating tools and resources to address provider burnout and burden. This is accomplished through sustainability and meaning of work, increasing that clinician and staff satisfaction, teamwork improvement, leadership improvement, and ultimately that quality culture improvement on site. Throughout the years, I continue to see on a daily basis the impact that a strong transition of care program can have on patient outcomes. There's been several journals, articles, and the work that we've been able to complete to show the effectiveness of a pharmacist-driven transition of care program, not only to decrease all-cause readmissions, but also to help decrease harmful adverse drug events, meet quality metrics such as the AHA Get With the Guidelines on Heart Failure, the ACC accreditation for heart failure, meet Joint Commission National Patient Safety Goals or Leapfrog Group surveys to implement 24/7 MedRec programs, as well as pharmacist counseling and follow-up has shown to increase HCAP scores by close to 15%. In addition, if a hospital has implemented a meds to bed program, pharmacists can help drive to increase prescription capture, which can then lead to increased revenue. These are all in place to not only ensure an improvement of reimbursement rates, but of course, ultimately improve patient outcomes. And thus, we've developed a program to impact transition of care from admission to discharge and into the outpatient setting, all with the goal of that hitting on those quadruple aim of healthcare, reducing readmissions, increasing reimbursements, improving on quality metrics such as the Leapfrog Group or Joint Commission and CMS compliance on MedRecs, and also increasing the HCAP scores and improving staff satisfaction. And when many people think of a patient care loop, they always think of it as going from admission to inpatient to discharge, and then potentially to a nursing home or into the outpatient setting. I see it more so kind of closer as kind of gears or bike gears, where if a proper admission is completed, the discharge will be smooth and lead to a healthier and a more optimal setting in the outpatient side. And thus, as I kind of mentioned, we developed our patient at home journey from admission to inpatient and discharge and thereafter, and really trying to cover all the areas that pharmacy can play a role to close any gaps within that patient care. So starting on the bottom left here with admission, our pharmacist will ensure that that medication list is as accurate as possible, speaking with the patients directly to ensure that not only any drug interactions, over-the-counter medications and supplements are addressed, but then also if there's any compliance concerns, that those are readily documented and alerted to the provider. And through the years, even after a nurse, a provider, a technician completes that medication history, we find close to 2 to 4 discrepancies on top of that, all with the goal of helping reducing those adverse drug events from occurring. Then as we move more into the inpatient side, having a pharmacy team available 24/7 to ensure that there's first dose review happening and following any hospital's policies and procedures. In addition, ensuring that there's any antimicrobial or opioid stewardship programs have a continuity of care aspect to it as well. Then as we move more towards the discharge side, Our pharmacist will counsel that patient on any new, change, or discontinued medications, but then educating the patient on any disease state management. So if the patient has heart failure, ensuring that they're checking their weight, or if they've had a stroke, ensuring that they've checked their blood pressure, looking at any formulary conversions as well. So perhaps a patient was taking omeprazole at home, was changed to Protonix in-house, ensuring there's no duplicative therapy as well. And then communicating that back with the provider. Then if that patient goes to a facility, following up with that long-term care facility or nursing home to ensure that a pre-admission chart and med review is occurring, looking for any formulary conversions that may be occurring at that facility, but then also looking for any antibiotics or anticoagulants to ensure that there's appropriate stop dates in place. If that patient is going home, following that patient for the full 30 days post-discharge, calling them on day 2, 7, 14, 21 to address any clinical or compliance issues, as well as re-educating that patient. Obviously at discharge, there's a lot of information being thrown at that patient. So giving them a chance to get home, go through their paperwork and help answer any questions, but then also making sure that the patient is aware of any follow-up appointments that they may have, and communicating that all back with the site and having that communication pathway open, which we'll dive into more here shortly. And then if that patient, of course, goes more into the outpatient setting, following that patient as they go to their primary care doctor and doing any chronic disease management on a monthly or bi-monthly basis as well. Now, to dive deeper into the 4 aims, let's see how TOC can improve on the patient experience. As a pharmacist, you can review admission and discharge summaries like I alluded to, updating that patient's record for accuracy and ensuring that the pharmacy is accurate. So if the doctor does order anything at discharge, that the appropriate pharmacy is being sent those prescriptions. Also looking for allergies. Obviously there's patients that say that they may have a penicillin allergy when in reality it may not be a true allergy, and having that conversation with the patient as a pharmacist can, but then addressing any patient concerns. In addition, communicating with the various providers and specialists and healthcare team members of those concerns, both on the inpatient and outpatient side. And that's what we've done here at CPS. We bridge that communication gap between patients, providers, specialists, case management, and nursing to allow for a seamless transition of care process, which improves that patient experience. By having these conversations with the patient during each step of their hospitalization, it can lead to an improvement in HCAHPS scores. Most of you are, of course, aware of the hospital consumer assessment of healthcare providers and systems, or the HCAHPS survey, that essentially is a patient survey where there are several questions that pharmacists can impact with their role in transition of care. We've seen some really great results of pharmacists increasing that Press Ganey HCAHPS scores related to medications. There's as well as on their disease state management after they leave the hospital, because there is just so much information being thrown at that patient, giving them a chance to be able to kind of digest it all and being able to feel comfortable in a setting where they can ask those questions and not feel that they are being a burden to the providers as well. Then, as we look to reducing costs, there's a number of ways that we can look at this. When looking at a return on investment or ROI, there's of course some soft assumed savings by helping prevent admission or discharge errors occurring, but then you can also look at labor savings to help prevent duplicative efforts by either nursing, the providers, or whomever else within the pharmacy team. And then finally, you'll have to have an impact on quality. That'll lead to a mindset change, as I alluded to earlier, with the hospital to improve on patient outcomes by having minimum changes to their operations. This will lead to improved nursing and physician satisfaction as a whole. Then, as we shift towards the improvement of health of the population, it's important to determine which patients to focus in on to ensure that transition of care programs will impact the highest risk patient population. It'll be necessary to stratify your patients. I've seen a number of hospitals utilize different tools. There's the hospital readmission reduction program that CMS puts out that that lays out which disease states should be focused in on. There's Boost scores, EPIC, predictive analytics models, or the LACE Plus index, all of which have their own separate criteria of what to be considered a high-risk patient. Though for the most part, you can see some similarities between those patients. I think it really helps to understand what your patient population is at your site and where you can have kind of that, for lack of a better term, the biggest bang for your buck and really drive home a reduction in readmissions. And then, once again, when it comes to the health of the population, pharmacists are the medication experts. They understand guideline-based treatments and ensuring patients are on the appropriate medications. And, we've been able to impact hospitals as they work towards meeting the AHA Get With The Guidelines on heart failure, as well as the gold standards for COPD. And some other quality metrics that pharmacists can play a role on, as a whole within the health of the population include ensuring that upon discharge, the patient receives a prescription for short-acting bronchodilators for rescue use if they're asthmatic or have COPD. If the patient is a current smoker, that they've been counseled on the need for smoking cessation through appropriate education material, pharmacologic interventions, as well as referring them to to the tobacco helpline or classes as well, if the hospital has classes available. And then if they've been discharged home, having that patient get follow-up calls, throughout those first 30 days where they are at the highest risk of being readmitted. But then, even after those follow-up calls, making sure that they feel comfortable communicating with their primary care providers. There's been a lot of studies and information sent that patients many times don't know how to best communicate with their providers, ensuring that patients have their questions readily available. If they are just being discharged, that they take all their medications to their doctor's office and that they feel comfortable with the medications that they are taking, or if there is any hesitancy, being able to advocate for the patient. Many times, as I'm sure many of you are aware, there is a lack of for lack of a better term, that there's a lack of trust built between multiple providers for that patient. And so if you can advocate for that patient, it's going to go that much further in developing and improving that patient's overall outcomes. And then another key component that has made our TOC program successful is utilizing best practices and gold standards when speaking with the patient, looking at organizations such as the Leapfrog Group or Joint Commission to ensure that conversations that are being had with the patient are capturing all the information that's needed. So as I mentioned earlier, not only looking at, if the patient is taking certain medications, but then why they're not taking certain medications, if there's any compliance concerns or drug interactions, being able to call that out so the provider can that much more quickly ascertain what changes need to be made to the patient's care. And then in the final aim, ultimately, a pharmacist-driven TOC program improves that provider's work-life balance. With so much documented burnout happening nationwide, pharmacists are in a keen position to help provide support to providers and nurses. Physicians now know that their patients will have a second set of eyes at admission, discharge, as well as post-discharge. And it doesn't just fall onto the nursing or case management team. So what are some barriers to a successful transition to care program? And, well, some common concerns I've kind of heard throughout the years is, how do you implement a program throughout the hospital? There's multiple projects happening at once. There may be a lack of pharmacy resources or a lack of technology support, and there may be insufficient recognition from leadership as well. We've tried to address those barriers by developing seamless integrations and workflow and process maps, and really calling out who may be involved in each step. And so if a nurse is needed in a specific step, calling it out. Ultimately, I think, what we've noticed through the years is within the first week or two, you may get pushback similar to any, overall project that the hospital may be utilizing. But within the first week or two, both, the nurses quickly realize that they no longer have to do either the admission workup or the discharge workup, and providers have that second set of eyes and know that their patients are having the information that they're utilizing is accurate. We work closely with the IT and the IS side to not only develop a safe and secure connection, but as we discussed earlier, looking at the stratification of those patients, especially at discharge, and determining what patient population that you would want to focus in on for helping reduce readmissions, as well as improving on other quality metrics. Having daily, weekly, and monthly calls with any involved stakeholders, if that may include case management, leadership, as well as someone within the provider team. And if it's on the admission side, working closely with the ED, if it's on the discharge side, working closely with the different nursing unit leaders, and having that conversation continually to improve on that program. And then being able to provide high-level reporting and presenting that data to leadership is ultimately the goal, because obviously, when we think of transition of care and the quality side of it, it's all well and good, and you can see some results from it, but we want to be able to drive home that pharmacists can play a leading role in transition of care, not only helping reducing that burnout and the staff satisfaction and increasing the staff satisfaction, but ultimately improving on patient outcomes, reducing adverse drug events, and improving on readmissions. And many times a lot of folks think that it has to be such a large uplift. We've gone live within 2 to 3 weeks of a program and getting it kind of uplifted throughout the hospital. It doesn't have to be an all or nothing approach. I think it's many times seen that way, but if you want to even start on a specific subset of population, or focus in on a specific unit and grow from there, I think that's where you'll kind of get the buy-in and the success as a whole. So to share some of our impact, through the years, CPS has completed over 75,000 chart reviews, and in that time, we found close to 180,000 interventions. And some of those, may be smaller, where a patient had a wrong formulation or a wrong strength listed. But just in the past year alone, we found close to 1,900 errors with just insulin and anticoagulants. And one that always I like to share during any of my talks is there was a nurse that had entered in. A patient was taking Lantus 40 units because that was what was listed on the patient's medication list that they brought in. Our pharmacist saw that the patient hasn't had Lantus filled in quite some time, but had been switched over to oral antiglycemic, I believe Convoglyze. And during that time period, they had been switched, been a few months. We updated the medication list, spoke with the provider, but just an example where if that patient did get the Lantus, it could have led to a hypoglycemic reaction, potentially extended their stay in the hospital. Another key component is that we're available 24/7. So regardless of patient volume or PTO, that medication list, at least on the admission side, will be accurate at any given time. For lack of a better term, many hospitals have too many cooks in the kitchen. And so one nurse may do it one way, a provider may do it a different way, a technician may do it a different way. Our team does this day in and day out, and has kind of those built out processes to communicate with the patients and the providers on those accurate medication lists. At one of our other facilities, they utilize the internal metric, which they said pharmacy review of MedRecs within 24 hours of admission. And that increased from 45% to 85% within the first week of going live. And on the discharge side, at one of our sites, we were able to reduce readmissions by 6%. And another, we were able to increase HCAP scores by 15% on medication-related questions. For another facility, we were able to improve on their their leapfrog survey metrics by implementing a 24/7 MedRec process. And as I kind of just mentioned, but with the leapfrog group, they had that hospital, the health system had limited achievement when it came to MedRec. And then once we had gone live by having this in place, they had achieved that standard and lowering their admission omissions for their patients as a whole. And so how do we implement this type of program and make it successful? The biggest driver is education. Educate, making sure that not only the pharmacy team is aware, but then also looking at providers, nursing, case management, value-based care, transition to care is a team-based effort. We've always tried to say is, pharmacy and CPS we can take the uplift of it, but it's still dependent on others to make sure that it's as successful as possible. And so helping others understand that the ultimate goal is to improve patient outcomes and what their role and being able to kind of support them and not feeling like they have another task to do, but rather that this is helping take some of that workload off of them. But then also being able to collect data, as I mentioned, to show that value through cost savings or cost avoidance as well. And so in conclusion, the role of the pharmacist is changing. Clinical pharmacists are working closer with the healthcare team, either by rounding or meeting with them remotely. Regulatory bodies, CMS, and private payers are looking closely at value-based care and constantly adjusting to that. And now technology, more so than ever, allows pharmacists and other healthcare team members to provide the same exact care remotely. And so with that, I'd like to, before we help open it up to questions, I'd like to turn it over to Dave to just talk a little bit about some additional services that CPS offers.
Great, thanks, Alap. So I've got really one slide, and then I know Todd wants to talk about one. He's got one slide for 340B, but just to back up for a minute, as I think Alap mentioned in the beginning, CPS has been around and in business for over 50 years. And we partner with over 800 hospitals nationwide in varying capacities. And so I just wanted to take a minute. I thought it was worthwhile to mention a couple other areas where we bring value to our hospital partners that are of high impact. Because I get asked often, what else does CPS offer in the way of pharmacy resources and pharmacy services? And in this day and age, I know everyone's looking for ways to decrease costs, increase quality, especially with the inflationary pressures on the cost side of things. It's kind of top of mind for everyone. So a couple things in our pharmacy consulting division, I'll just mention a couple of things off of here. We've got a clinical resource partnership model where we partner with you, the pharmacy team, to help identify, implement, and maintain a greater amount of clinical initiatives in a compressed time frame than might be possible without these added resources, and also without you all having to budget and add clinical staff and deal with budgetary constraints. So it's a resource that it allows speed to quality, speed to savings in a budget neutral model that we have. It's additive to everything that you're already doing on the clinical side. But what really resonates about this collaborative model with CPS is that, we routinely find 10 to 15% medication cost savings that we can help to implement and maintain, and our fees for that partnership are 100% at risk, so it's budget neutral at worst. A couple other areas that we work with is, you'll see focus areas, interim leadership. So, if there is a need if there's a vacancy in pharmacy leadership that you all would like us to help kind of fill while you all recruit. We also have a hospital we partner with right now that the director went out on maternity leave and just needed some interim leadership for the 3 months that she's gone. So we can kind of fill those types of gaps. And then finally, we offer many different audits and assessments, from USP to operational audits to controlled substance assessments and many others. Really, we can build a service set from a consulting side to really fit any need you might have in pharmacy. So thanks for letting me talk through those services and the additional value that we have for a lot of our other hospital partners. I'm going to turn it over to Todd for a couple minutes on a high-level 340B overview on how we can help there as well for those that are covered.
Sure, thanks, Dave, and glad to share with you. As Dave mentioned, We offer a number of different reviews for our hospital clients, and specifically as it relates to 340B, we offer a very rigorous audit review of over 100 data points, which cover both a mixed use as well as a contract pharmacy. I like to say that our expert team, all of them are APEXA certified experts, and they're all pharmacists or pharmacy technicians, and all of them on the team, it's approaching about 15 now. It's a robust team, come from a hospital or a health system background. We have all of the designations represented, with our combined team tenure in 340B approaching 200 years. So it's really an elite team that represent CPS. They speak at national conferences on a regular basis, and they generate significant results, both in terms of compliance as well as 340B optimization. The one thing I love to throw out there that sticks in a lot of clients' minds is we've performed hundreds of audit reviews over the past 4 years since we've been tracking this metric, and we have yet, knock on wood, to have one client go through a live HRSA audit where there's been a surprise audit finding gap, error, or omission that had not already been called out and recognized and addressed by a CPS reviewer for our clients. So we have a 100% accuracy rate for predicting and identifying all gaps in our clients' programs over 4 years. So we're pretty proud of that metric. We have a number of additional compliance services, year-round retainer services, as well as 340B optimization that really generates or helps our clients squeeze every last dollar out of the 340B program, with programs such as 340B ESP assistance, as well as referral capture and some other services. So happy to talk with you as well on that front if any of those would resonate with you.
Great. Thank you so much, Dave and Todd. Like to kind of open it up now to any questions, Andy, if there's any that have popped in. Or
If there's any questions, please put them in the chat. I will read them off and we'll get them answered. And we kind of wait for people to put any questions in that they might have. Just want to reiterate, CPS has been a great partner with us for a number of years now. We have several locations utilizing their service for primarily after hours, but sometimes it's a 24/7 need in some cases. And, it's been a good partnership over the years. We get good reviews from our customers who are using your service. So we appreciate the partnership we've had with you guys over the last several years. Do we have any questions that anybody wants to ask? I don't have any in the chat yet. We're a little bit of a small group, so if you have one, maybe just unmute and let's see if we can answer. Give everybody just a couple minutes here. While we think about that, so if someone was interested in the Transitions Care program, you can reach out to us, either myself, Shane Fleming, Jana Tanner, who is our customer success advocate. Any one of us can get you steered in the right direction, get you information on that. I guess, Olive, what would you suggest people think about, if they think that, this might be something they want to pursue? How would we start to engage with you on their behalf?
Yeah. Great question, Andy. I think, one of the biggest drivers is trying to, and I tried to highlight it a few times, but really understanding what the patient population and the need that you have, if it's either on the admission side or the discharge side or the post-discharge side.
Mhm.
I think one kind of thing just noticed throughout the years, and maybe a little bit more anecdotally, but no two hospitals are the same. Every hospital has its own pain points. And so addressing those individually and trying to figure out where a transition care program can have the largest impact. Obviously, the goal would be to have pharmacy driven, as a pharmacist, to have pharmacy driven admission, discharge, and post-discharge transition care programs. But, realistically and looking at where you can play that largest. So, some of our facilities, we say it's never cookie cutter. And so some of our facilities, we do admission, medication, history, and reconciliation on all patients. And then for some, we do just discharge, and we just do discharge and post-discharge on a heart failure and stroke patients. Others, we look at a readmission score of 12% or higher. And so once again, trying to work with your quality teams, your chief quality officer, your nursing leadership on where the biggest gaps may be. And I think that's usually a good start to then try to build out what a program may entail.
Yeah. And do you suggest maybe as they're looking at transitions of care, looking at specific disease states to start with, or is there,
Yeah.
a guidance you can provide there?
Yeah, so obviously there's kind of the big ones that CMS calls out. So, heart failure, COPD are usually kind of the two big ones that are up there. But if there's other risk scores that your hospital may develop, we've had sites use the BOOST score, which tries to take into place age, comorbidities, as well as what their medications may look like, and kind of build a score. And so we focus in on patients that are 4 or higher in terms of that risk of being readmitted. I would say usually on the admission side, most facilities like to have kind of an all or nothing approach. Obviously, the goal with admission is ensuring that every patient has an accurate medication list, so that the providers can ultimately make that decision and determine what they should be taking. And then at discharge, really focusing in on some of those high risk patient populations.
Sure. Okay. Well, I don't have any other questions in the chat. I think this has been really helpful today. Appreciate you guys joining us. So we look forward to further educational webinars coming up. I will have emails going out about that in the future. But really want to thank the CPS crew today for joining us and tell us a little bit about transitions of care and some of the other services they provide.
Thank you. Thank you all again for the time today.
Thanks, everybody.
Take care. Bye.
Bye.
Thanks, everyone.
Thanks. Bye-bye.